have a question for Michael and John actually about ibrutinib, and it has to do with toxicity and two issues. One, Adrian Wiesner just published some data suggesting that PCP is occurring a little bit more than you might have expected, not related to T-cell count, so that's one question about toxicity. And the other is dealing with the practical issue for really the audience is really dealing with the atrial fibrillation, which is not common, but not uncommon either. And so maybe either one of you might address that.
I'll address the pneumocystis, and Ray Weiss, in mentoring me, told me that it's really hard to report toxicity with a drug that everybody's excited about, and that's true. And so that paper, we were happy to publish that paper at Blood, but if you read it carefully, because if you read the paper carefully, we probably missed pneumocystis in some patients. It occurred relatively early, and it wasn't the blowing ill pneumocystis that people die from. Again, most of the studies we use prophylaxis in our study, and so it's something that we most of the studies, so we may have missed it, and I think it's a worthy safety thing, but it's probably not a big safety concern for for ibrutinib, say much less than atrial fibrillation or the bleeding diatheses that can sometimes occur.
Yeah, we don't use PCP prophylaxis in our ibrutinib studies at all. And I think that we've only seen 1 or 2 cases of PCP, and it's usually in patients that have had multiple treatments, and many of them have actually had corticosteroids as part of treatment for autoimmune hemolysis, etc. And if you go back to the old days, we saw almost no pneumocystis with fludarabine alone, despite the fact that it was a dramatic T-cell depleting therapy. But as soon as Susan O'Brien added, the prednisone to the fludarabine, the pneumocystis began to appear, and so that there are specificities about the immunosuppression that we don't really understand fully. But we talk about the atrial fibrillation being not common, but it's the common thing, the common complication which causes me most angst. And the patients are very nervous about it, and they talk to their doctor, and you're going to have a stroke, and you have to be anticoagulated, but we can't use that nasty warfarin, so we'll do one of these new, less nasty, allegedly, treatments along the way. And it really does disturb the patients a lot. And
there's sort of 2 patterns of AFib too with that. I mean, there's the early kind that occurs usually within the first 3 months, where almost always, if you continue the drug, it's going to continue happening. But your point as well, and whether it's warfarin or any of the new anticoagulants, people will bleed with this with this drug, and so it puts us in a good position, though that there are several more selective BTK inhibitors that are coming along that lack some of these alternative target effects. Acalabrutinib, there's an abstract that was that was going to be presented at this meeting, showing that in most patients who are intolerant for one reason or another, they can go on to that. So we're sort of following the path of CML, where the second generation molecules, they have their own side effects, but we're going to have a second generation molecule, hopefully, that will be available to patients that don't tolerate ibrutinib.